We're now live, Chair.
Thank you, Kirsty. We're just waiting for the magic number, and the magic number has appeared. So I'd like to welcome you all to the Adults Health and Social Care Scrutiny Board on Thursday, the 17th of June 2021, our first meeting of the year. I'm delighted to once again to be chair of the Adults. We've got some exciting plans. I'd like to welcome Josh, Councillor Fenton Glynn on board as the new portfolio holder. I'm sure we'll love to work with you in the future and scrutinise some of the things that you tend to bring to us and move forward. We have a few new members, and we've got this evening we do have quite a few substitutes. So welcome Councillor Benton as a new member of the panel, and thank you for the substitutes that have agreed to attend on behalf of the other people that haven't. So we'll get there somehow. So let's get on with the agenda tonight. So substitutes nominated for this meeting and apologies for absence. I'm going to let Kirsty read them out if that's okay.
Yep, that's fine. Chair, we've had apologies from Councillor Durans, Kingston and Parsons Hulls. Substituting on their behalf are Councillor Clark, Councillor Smith and Councillor Holter. Excellent,
superb. Equally like to welcome Fazana on board as our scrutiny support officer. She's recently been promoted, so congratulations. We'll like working with you before, so we're going to look forward to working with you in the future. So item number 2 is members' interest. To remind members to declare any interest that they may possibly have at the relevant time. You can either indicate at the beginning of the meeting or as and when they come across. I'm sure it's easier as and when they come across. So item number 3 is the admissions to the public. The public is on YouTube, so welcome anybody that's watching on YouTube. I hope you find this very informative. It always is. It's always a friendly scrutiny. We will always work together. And one thing we do tend to find it tends not to be political. We tend to do it for the best of what we're scrutinising. So just for information. Right, so minutes of the Adults Health and Social Care Scrutiny Board, item number 4, held on the 11th of March 2021 and the 8th of April 2021. They've all been circulated, so can I send those as a true record? Can I have a proposer? Thank you, Councillor Hutchinson. And a seconder, Councillor Barnes. Thank you ever so much. Any comments in relation to that? We don't normally accept comments, but it is quite some time. Anything we need to pick up from there, if we leave it to the work programme as well, I think, on that one. So, right, item number 5 is the COVID updates. On this meeting, on this panel, we normally have over the last 12 months, we've had a COVID update every time we've met. It's been most useful. And I think really it's just an update as to where we are from the last time. Some basic questions you can ask the members, but if I can go into just looking who's actually here at the moment. Ian, would you like to start us off on that until we get Debs on board?
Can I just stop Ian for half a minute?
Of course you can, yeah.
Thank you. Have you been taking something? I didn't know you could talk this fast. And I wanted to comment on the minutes. Now I'll do it later, but I do really want to comment on the minutes. Okay?
Yeah, absolutely, Megan. Yeah, absolutely. No problems at all.
To go past that was all.
Yeah, indeed.
Yeah, thank you. Thanks.
Yeah. I can see Debs has joined us. Debs, welcome once again to our panel. It's really nice to have you on board, as always. We'll start off, whilst you miss, I was going to start off with Ian, but actually I think it's more appropriate if you would like to, we're on item number 5, which is the COVID update. So if you'd like to lead on that, that would be most helpful.
I'm so sorry, Chair, for being late. I had some technical issues. I couldn't get on, so apologies for that. So, so I'm just going to give a brief update on where we are with COVID-19. What we have, I'm just get the actual numbers in front of me. In the most recent 7-day period, the 6th to the 12th of June, 263 Calderdale residents tested positive for COVID, and that gives us a case rate of 124 per 100,000, and that is an increase of about 75% from the previous 7 days. Now that's a massive increase in cases compared to where we were just a few weeks ago. 2 weeks ago, our case rate was 50 per 100,000. So you can get a real sense of the increase in cases. The vast majority now of the cases in Calderdale are the Delta variant, which is the variant that was first identified in India. About a week ago today, it overtook the Alpha variant, the variant first identified in Kent, in terms of the making up the majority of cases. So you're getting a real sense of the pace of change. The good news is that that we're still seeing only a very small number of people in hospital with COVID-19 at the moment. So the most recent information that I had as of yesterday, there were 7 people in hospital that were tested positive for COVID-19. That's across. That's in Calderdale and Huddersfield Foundation Trust, so that's across Calderdale and Huddersfield. So at the moment, we're not seeing the increase in case rates reflected in people with serious illness and in hospital, which is really good news. But obviously, what we want is we don't want that to happen. We want it to stay that way. So what we're doing is we've really stepped up the preventative work that we're doing in Calderdale. So we're doing a number of things as part of that work. One thing that we're doing is we are doing extra testing. So we've got a very large, actually, and growing extra testing programme where we're inviting people in key areas where we've got either increasing or high case rates to go and get a PCR test, whether or not they've got symptoms. It's a really important thing that people can do to do the bit for us to try and keep the lid on the increase in case rates. So that's the first thing that we're doing. The second thing that we're doing is at the point where we're inviting people to get those extra tests, we're also making sure that we're really promoting and they're aware of the support that there is to self-isolate. So the financial support and the other support that's available as well. And again, that's proving really successful. We've had a big increase in the number of people that are applying for financial support, for self-isolation, while we've been doing that. So that's really important because that's what helps us break that chain of infection. We're also in the areas of the borough where we've got high case rates and increasing case rates. We're doing a lot of work to engage with the community. So what we're doing is we're talking to the community about testing, about the vaccine, about support to isolate, and about the increase in case rates and the things that they can do to reduce the chance of coming into contact with the virus. And then finally, as you'll be aware, and most importantly, actually, we're doing a great deal of work to promote vaccination. So we're really looking at taking vaccinations to places where people are, really stepping up, making it as easy as possible for people to get access to the vaccination. So focusing that on the groups where we've got people only just become eligible to get the vaccine, so the younger adult age group, 18 to 25-year-olds, and also in the areas of the borough where we've got slightly lower uptake of the vaccine. And that's really important. And ultimately, Councillor Bagbo, we're in a position where we're in a race between the variants and the vaccine. So what we're doing is we're doing everything we can through the extra testing, through making sure people are aware that the Delta variant is with us and it spreads much more easily, to keep a lid on the case rates while we get as many people vaccinated as possible. So that ultimately is sort of, I guess, the key points of the update and where we are. We've got what we're seeing in terms of how the virus is spreading is that we're seeing the highest case rates in at the moment are in the young adult age range who have only just become eligible to get the vaccine, and also so really people between 16 and 25 is where we're seeing the highest cases. We've got a small number of outbreaks in schools and early years settings at the moment, inevitably where people come together. We haven't actually at the moment got any workplace outbreaks that we're aware of, or any care home outbreaks that we're aware of, again, which is great news. And when we look at where people are coming into contact with the virus, what we're seeing is schools and early years settings, workplaces, and then the places where people come together now they're allowed to, with the stage right at the roadmap. So events, hospitality, and leisure activities are where we're seeing people come into contact with the virus. So that's it, Councillor Blagborough, in terms of my update.
Super.
And as I say, apologies for being late.
No, don't apologise at all. Thank you very much indeed for providing us with the update. I noticed, I think the Peace Hall are doing vaccinations over this weekend. So a place like that is absolutely amazing. So just members, if you want to indicate to speak, if you click on participants and there's a function to raise your hand just in case you're not aware of that. So we've first of all, we've got Councillor Hutchinson followed by Councillor Barnes. So Councillor Hutchinson, please.
Thank you, Chair. Deborah, it's really heartening to hear that the promotion of the support that's available is being given out where people are actually having the tests, so that they're prepared if they get a positive result to get the support that they need. But I was wondering on the contact tracing side of things, we've heard for quite a long time now that there was going to be a greater degree of contact tracing done locally, rather than just as an afterthought when the national system doesn't manage to get in touch with people, and that would be extended to include the contacts of cases. What's happening with that?
Yeah, thanks, Councillor Hutchinson. So yes, absolutely. We, as you know, participated in a pilot some time ago. Actually, just one or two councils actually that piloted reaching out to the contacts of cases as well as cases, and as you know, that was incredibly successful. And actually, we were given the go ahead to take that on. I understand from the contact tracing manager that we'll be starting that next week. They're contacting the contacts, and we've also applied and been given permission to do something called Local Zero, which is do everything, take the whole thing on. Again, we haven't had a go-ahead, a start date for that. That relies on some work being done nationally, so that we can a button can be pressed so that the cases come straight to us as opposed to through to NHS Test and Trace. But Joe informs me that the step one of that, which is contacting the contacts, will start next week, and that we're working with NHS Test and Trace on a timescale for Local Zero. My understanding is we've had the go ahead. It's just about the start date for that. So I think that's great news. Now, just to say, well, I've got the opportunity really that you know, our contact tracing team have been absolutely amazing. They're really skilled in tracking people down that other people haven't been able to contact, and as well as the amazing work that they've been doing with trying to help us contain the spread of the virus. The team are also now doing some fantastic work reaching the people who haven't yet had the vaccine, who are in the highest risk groups, who the GPs haven't managed to speak to, so haven't managed to offer a vaccine to, and are doing a great job of getting hold of those people, talking to them, if they can, arranging for the GP to call them or booking them directly a vaccine themselves. Quite often the details are wrong on the GP system, and they're managing to track them down and make sure that those people that are most at risk of ill health if they catch COVID, are actually getting that offer of the vaccine. So I think it's a phenomenal skill set and a great team of people, and I'm really proud of them all. And I know Councillor Hutchinson, you're one of them, so thank you to you for volunteering to do that as well.
Yeah, and thanks, Deb, once again for all your hard work in continuing to move things forward at a very, very fast rate as we speak, and I'm sure is recognised. So I've got Councillor Barnes, Councillor Smith, and Councillor Megan Swift. So Councillor Barnes, first of all, please.
Thank you, Chair. And I think Deb stole part of my thunder, because I was going to say there are always exceptions to the rule on the contact tracers, and I think Councillor Hutchinson might be in that exception. But a couple of quick questions. One, something really following up from what Councillor Hutchinson Collins said, which is the self-isolation. And whilst it is great that support is happening there, are we then following up with those individuals who have been tested positive with regard to that? And the second one is just a quick one. Do we know the sort of ages and whether there are any underlying health conditions of those that have been hospitalised? Because obviously, you know, that was what was always said about about COVID, was that it impacted more heavily on older age groups. So it is perhaps surprising to see that there is an increase in that. So is there any data on that yet?
Yeah, I mean, in terms of the follow-up of the people that test positive, yeah, that's absolutely what the contact tracers do. They get in touch with them. We also get information about people that need a bit of extra help. Also, if anybody that's clinically extremely vulnerable tests positive, and our contact tracers get in touch with them and have a chat with them and make sure that they're getting the support that they need. We are, as I said earlier, we've seen quite a large increase in the proportion of people, in the applications of people for financial support as well, and again, and an increase in the proportion of people that are getting successful applications for that support, which is really, really good news. And as you know, we've discussed this many times in this board, and it's something that communities talk to us about all the time. So I think that follow-up, that absolute wraparound support for people to isolate, whether it's to take your dog for a walk or to get you shopping or to have enough money so that you're not out of pocket, is all really, really, really important. In terms of the data about the people in hospital, we don't routinely collect the information about the ages and the vaccination status and the long-term health conditions of the people in hospital that test positive. What happens is actually that as you know, that anybody that's admitted to hospital will be tested for COVID when they're admitted, and tested periodically during the stay. So what we don't know routinely is whether people are admitted because of COVID, or they're admitted to hospital with another health condition and then test positive for COVID. So we have regular meetings with the medical director of the hospital, and we do, get information and sort of do profiles, if you like, of the people that are in hospital. It's probably because of the very small numbers that are in hospital at the moment with COVID. It's probably not appropriate for me to sort of give any information about some of the vaccination status, etc. Just because it's such a small number, it might be possible to identify some of those people, but just to be assured, we regularly sort of look at that sort of information, and just to say, the majority of people in hospital aren't fully vaccinated yet, although there are people still, as you would expect, because no vaccine is 100% effective. There are people in hospital that are fully vaccinated as well, but they may not be in hospital because of COVID, if that makes sense. They may be in hospital with COVID, if that difference makes sense.
Thanks, Deb. I think Neil is putting in something in the messaging. So would you like to come in on that, Neil, just to reiterate what you've just said? So Neil, you're on mute at the moment. Neil's from the clinical commissioning groups, and he's just going to unmute himself. So if you'd like to just, no problem.
Sorry,
much better, yeah.
So I think, as Deb says, we are seeing such small numbers compared to previous sort of waves, but we are starting to see waves across West Yorkshire, with the medical directors talking yesterday. Unfortunately, this is sort of unsubstantiated, but we are seeing that it's a younger cohort, which is correlated by the statistics that are coming out from the northwest and London, where they are seeing significant increases we're also seeing that some of those correlations are due to where they're not as advanced in the vaccination program as ourselves. So we are sort of priding ourselves in West Yorkshire, particularly in Calderdale, and the take up and the sort of program that we've delivered since sort of early December. We're in a really good place with our coverage, and those that are seeing higher hospital admissions are those that are further behind, particularly on the lower cohorts of JCVI cohorts, sort of from 9 to 12 downwards. So they're seeing it very much. The statistics are proving to be in the lower age group, 40 to 60, rather than the higher age groups, which we saw before. So that is consistent across the UK, not just in West Yorkshire, and a majority are being unvaccinated. I think in West Yorkshire, we found that one was vaccinated, but they were vaccinated very early doors and didn't go back for their second dose. So hence, there's a huge body of evidence coming out now that the second dose, particularly for the Delta variant, is really important, which is why we've got a big push on over the next few weeks to ensure second doses are done at the 8-week mark for everybody to ensure we've got that maximum coverage.
Excellent. Thank you, Neil. Councillor Audrey Smith, if you're still here, yeah.
No.
Thanks.
Question.
Oh, sorry, I think you'd had your hand up at one stage. Councillor Megan Swift.
Thank you. I mean, you know, it goes without saying people are doing a fantastic job. But a comment, please, if you don't mind. The press yesterday and the television were talking about people working in care homes actually being forced to vaccinate. I don't like the word forced. Can you comment on it?
Ian, would you like to comment on that, please?
Thank you, and thank you for the question, Councillor Swift. Yes, there was an announcement yesterday following a consultation, which was a consideration of whether or not vaccination should be mandatory for care workers who work in residential and nursing homes. The full detail of that announcement is yet to work through. I think part of our local strategy has always been to listen to staff who have been hesitant or reluctant to take the vaccine and engage with them and help them consider that. And I think what's important to probably just state as well is that currently in our residential and nursing homes across Calderdale, 82% of staff have had their first jab and 71% the second. So at the beginning of the vaccination programme, the expectation that was set in terms of where we thought it would be most clinically effective, it was set at 80%. So we are clearly working towards that. What this announcement does is suggest that all care staff have to be vaccinated as a condition of their continued employment. I think the headlines that were announced yesterday was that care workers will have 16 weeks from the date of implementation to get access to the jab. What we do know, and Deb's has already said this in terms of what our picture has been for the last few weeks in terms of care home outbreaks, we have had no outbreaks. So we do know that the current level of vaccination is holding within our care, residential and nursing home settings. We are going to do a piece of work, which we started yesterday, to understand the picture in all our homes, because obviously the global figure of 82% is based on all Calderdale homes. And what we want to understand is if there are any risks in individual homes, if, for example, a small number of staff would continue not to want to have the vaccine, but potentially then could no longer work in frontline care delivery. Because what we don't want to happen is for providers to suddenly have a challenge in workforce, because we know that social care is a really hard job and often it's very hard to recruit to. So potentially losing staff through the mandatory vaccination is of concern, but we're monitoring it. I hope that helps.
Thank you. Yeah, thank you, Ian, for that. Anybody else wanting to comment in relation to this particular item before I'll move on to Ian for a bit of an update on the care home side or any other further updates? No, right, okay. Ian, would you like to, is there anything you need to add in relation to the care home side?
I think probably not, because I think I've probably covered in the response
in the present,
about
yeah.
vaccinations. Just to add, though, that in terms of residents in residential and care homes, 94% of nursing home residents have received the first jab and 87% the second. So if you combine both residents and staff, there is a relatively good high take-up, which is not the same in all other areas of the country. And we've already talked about the fact there have been no outbreaks for some time in our care settings.
Excellent, thank you, Ian, for that. Let's move on to item number 6 then in that case. So 6.1 is public health. Debs, you're on the scene now. You seem to be taking the star role tonight, so welcome back.
Oh, thank you, Chair. So yeah, I mean, this is about just, I guess, setting out sort of the priorities and challenges for the coming year. I guess to inform, the development of a scrutiny plan and to think for the board to think about the issues and areas that to scrutinise. So I think I've written a little list down. So and I hope I won't speak for too long. So the first thing to say is that, I mean, the recovery from COVID is a massive priority really for the coming year. In a few levels, I guess, of that. There's the recovery of people's health and well-being from COVID, and there's some specific examples in there. There's the recovery of the public health function, actually, what we do as a public health team, because we have done mainly COVID and very little else, because we're a very small team in a very small council. So there's some work around the recovery of the public health function and the work we do. And then there's something about taking what we've learned from COVID and some of the fantastic things we've done and using that as the springboard to deliver better outcomes in terms of the health of our communities. So just to get a bit more specific, so that's a sort of bigger picture. So there's a number of areas of work that we've identified as priorities. One is for us to do some work on the health and wellbeing strategy. For us to we've got a fantastic health and wellbeing strategy that was developed in 2018 and published in 2019, and we're halfway through the lifetime of that health and wellbeing strategy. And actually, in light of what's happened with COVID, the Health and Wellbeing Board has made the decision to do a bit of work. The broad focus of the strategy is right. I think there's 26 or 25 priorities in that strategy, and the board is very keen to actually focus down on a smaller number of priorities. I think what we've learned through COVID is that when we really put our mind to something as a partnership to make a difference on a small number of priorities, it's amazing what we can achieve. And actually, what the board is keen to do is to do some work to really hone down a much, much smaller number, 3 or 4, for example, priorities that we really want to work together on and make a difference. So that, I think that's probably the first thing in terms of the priority for me as a Director of Public Health and for our partners, is to do that work, really get to the bottom of some really key areas that we can focus on. And that will be a challenge as well as a priority for us. I think the second area is really, and it links to this, is really in relation to recovering the health and well-being of our communities. And what COVID has done is it's really exploited inequalities in health that already existed in our communities. And actually, what's going to be really important is that we, in our recovery of the public's health, we take a strong focus on inequalities in health. We don't want next time a crisis happens for the impacts to be as unfair and as unequal as this has been. So really a strong focus on some key areas where we can really address inequalities in health. And as part of that there's some very specific things in relation to public health, but there's also some work around what we do as a partnership and how we work together as a partnership around inequalities in health and join up and integrate the things that we do to narrow the health inequalities gap. So one of the things that we're doing some work on, again as a partnership, is we've identified some high-level outcomes that we want to achieve, including narrowing the gap in health and quality of health, as well as quantity of health. And what we're doing is we're doing some work outside of hospital, thinking about community services, thinking about how we can identify small number, probably 3, either groups of the population or outcomes we want to achieve for groups of the population, and actually start to think about how we can join up healthcare and wellbeing services much more effectively to deliver those outcomes. So make the starting point of what we join up be what we're trying to achieve, the difference we're trying to make. What we've done before when we've focused on integration and joining things up is we've made the services the starting point, and I think that's limited our ability to really get traction. So one of the key priorities for us is that joining up. To help with that, there's some very specific things public health need to do, and one of them is really we need to be much better at joining up and sharing and integrating the intelligence, the data that we use, the intelligence, the analysis we do to really understand the health of our communities, so that allows us to join up the things that we do to achieve those outcomes. So really developing an outcomes-based approach, understanding outcomes, being able to measure outcomes and understanding the influences on health, and all of that to be using an approach that we call population health management, to really as a technique and a tool that we can use to really enable that joining up to happen. And also finally to join review and improve our joint strategic needs assessment that helps us set the strategy and priorities. And then a key priority for us as well is active Calderdale. You know that we've got a local delivery pilot, and we're absolutely determined to do everything we can to increase physical activity in our borough. We've got a great foundation to work on in that, but we really want to move forward, particularly create conditions in communities where it's as easy as possible for people to be active, and actually empower communities to do more around being active. So that's another key thing that we want to look at. In terms of the recovery as well of health and wellbeing, one of the things that we want to do but quite specifically in relation to recovering community health and wellbeing and focusing on inequalities is actually we want to empower and enable communities to decide themselves what needs to happen for their health and wellbeing to be recovered. So we want to do some work on using participatory budgeting, so that we work with community groups in localities in the borough to say, what are the priorities to improve, to recover health and wellbeing? What would you like to see money spent on? And how can we invest resources to enable communities to take action themselves to recover from COVID in terms of health and wellbeing? And then finally, a key priority for us is recovering mental health and wellbeing. And there's a number of elements to this that are really, really important. I think, first of all, in our NHS services, in our council services, in our voluntary and community sector services, we have employees and volunteers that have been traumatised completely by COVID, who are at risk really of having long-term sort of mental health consequences of the impact of COVID. So we're working with our colleagues in the NHS and the voluntary sector to look at to commission a programme of work focusing on staff and volunteers from our partner organisations to support them with their mental health and well-being. So that's a really exciting programme of work that we'll be working on, but really important. And then in addition to that, we are doing some work around suicide prevention for the wider community and population. So again, looking at our suicide prevention plan, looking at our mental health promotion plans, and thinking about how we can support. We are concerned that the crisis that we've been through is going to impact for some time on the mental health of our communities. So again, that's a key challenge, but also a key priority for us, Chair. So that's my sort of reflections on priorities and challenges. Councillor Blackburn.
Thank you, Debs. It sounds very comprehensive. It sounds like you're going to be working 48 hours a day, but you know, I'm sure a lot of the things you've mentioned. I think I've met with Councillor Barnes, and we're including it within the work programme. So hopefully we'll pick up some of those things. And for new members, don't worry about it. It might sound like a different language, but we can step by step. We'll get them onto the work programme and make it a little bit more, probably a little bit more understandable. But we understand, Deb. So thank you for that. So I've got Councillor Barnes and then Councillor Hutchinson.
Thank you, Chair. I think a comment to new members: you're going to have to learn to love triple letter acronyms on this committee. So I think that's a given. I think one thing I just wanted to sort of comment on with regard to Active Calderdale, and I think this is a point which I think there needs to be a sea change, a culture change, and I think that culture change needs to be in the council and council officers as well. And in particular, I would look at, let's say, the Safer Streets programme, where both Councillor Hutchinson and I are aware of a reticence within council officers to really actively engage with this. Now, yes, it is aimed at children, but it's the parents who are taking the children to school to avoid them getting into their car and driving the 100 yards that it is to school to drop their little child off and then drive the 100 yard back home. And I think we need to look at that and widen as much as possible the list of partners and the list of council departments that can be involved within this to produce a common goal. I think there's a truism where you're all working for the same goal and in the same direction. You will achieve it much faster than what is happening at the moment, which I think is the main arrow is pointing that way, but the individual arrows are pointing every which way but loose. Thank you.
Thank you, Councillor Barnes. I think that's really useful to add. I don't think there's anything else to add from the officer's perspective. So we'll move on to Councillor Hutchinson, please.
Yeah, thank you, Chair. One of the areas where inequalities, health inequalities seem to be very closely linked is with air quality and exposure to air pollution. We know that we've got a number of air quality management areas in the borough. It has been noted that close to the one in Sowerby Bridge, that the incidence of pulmonary disease in the nearest primary care practice is significantly higher than average. But I'm not aware that we know that for each of the air quality management areas. And I was wondering whether that information is easily available, or whether that's information that we ought to be going out and seeking, so that it could add some stimulus to the management of the air quality in these areas, and whether there are other sources other than road traffic pollution that might be a significant player to that in some of the areas that are maybe less obvious.
So would you like to come back in that? So yeah.
Yeah, it's a really good question, Councillor Hutchinson. Yeah, we did a little bit of work just looking at incidence of asthma and chronic obstructive pulmonary disease with the local practice station road practice in Sowerby Bridge, and found higher than average prevalence of both of those in that population. I think the challenge is that, and it is something we could do for the other air quality areas as well. I think the challenge is that there are other factors as well. It's very difficult with a quite small population size to identify the exact contribution that air quality is making over things like smoking and other sort of other risk factors, if you like. I think for me, the very clever people, much cleverer than me, who know much more about air quality than me, do a lot of work to really understand and quantify that contribution. For me, it's quite simple in terms of what we need to do about this. And actually, for me, it's about focusing on the things we need to do. And actually, it is about, increasing physical activity, increasing people walking and cycling to school. Just to give the example of Sowerby Bridge, that specific area, if we look at when the higher levels of air quality, the poorer air quality are, it's a school drop-off and school pick-up time. The measures that we can all take as I guess as organisations and as communities and as schools are around us, really trying to increase walking and cycling and scooting children to school as opposed to driving them to school, for example. That's a real challenge because it's a vicious cycle. If there's a lot of traffic, you don't feel safe. But there are some really challenging decisions, aren't there, about things like parking policy, about do we want to be the person that walks our children to school and doesn't drive them to school? Do we want to break into that cycle? So for me, I think we know that air quality affects health. We absolutely know that. The extent to which it specifically contributes to respiratory disease in particular areas is it takes a lot of work to find out, and there's a lot of challenges in quantifying that. But actually, I think we know the things that we all need to do to address those issues, really. And it is things like electric vehicle points and walking to school and using public transport and creating school streets and things like that. So I guess that's, I guess my challenge back is do we want to wait to get perfect data, or do we want to take action, I guess?
Thanks, Deb. I've got Councillor Megan Swift, then I've got Councillor Audrey Smith, and then I've got Councillor Holdsworth. Now, Councillor Holdsworth, if your question can it relate to the neighbourhood plan, but only on health matters, if that's okay, please. This is an adult health and social care scrutiny panel, so if it relates to health matters specifically, it does. Then they're more than happy. But let's go with indeed. If I can go with Councillor Megan Swift first of all, please.
Thank you. Excuse me. I think it's all right to ask these questions, but I won't be alarmed if you stop me, Howard. Okay. I think it's possibly for Debs. And there's two questions, really. I know how sensitive suicide is, and I saw some of the numbers a couple of weeks ago. Have we any idea where we can actually, and I'm trying not to say the place, but we have one place where a lot of people are doing this. Is there anything we can do with that place to stop it happening, or to make it more difficult for people to do?
Yeah, I think we have in terms of the numbers of suicides, we look at, it's quite difficult because a suicide is only a suicide once a coroner has sort of decided, if you like, and looked into all of the evidence and all the circumstances. One of the things that's really important that we can do is we can take measures, change the environment to make it more difficult for people to commit suicide in a particular area, and that's something that we are looking at across the borough. So where there are sites where we know that there are distressed people, that there may be people that are attempting or considering suicide, then we are doing work to look at putting measures in place to either make it harder, make it more difficult. I think it's really important that we understand, though, that in the most recent suicide audits that we've looked at, the vast majority of people that sadly that commit suicide in Calderdale do so in their own home, not in a public space. So it's really important that we work at all levels, to address this and improve mental health and prevent suicide. Thinking about it all in all places, spaces. And one of the things that's really important is about us talking about it being all right to talk about suicidal feelings. It's really, really important that people do talk about if they're feeling suicidal, that they talk about it and that they seek help. And that we really want to encourage people to it's okay to talk about this. Again, equally, the majority of people, sadly, that we lose aren't in touch with services, mental health services. Once they maybe have attempted to harm themselves, then they can get great, fantastic support actually from services. So it's a really important priority, and it's something that it feels really important that in light of the crisis that we've been through in society, that we actually look again at our suicide prevention plan and our mental health promotion plan and think about the things that we can do, whether that be about making changes to physical spaces or whether that be other support in the community as well.
Thanks, Deb. I think I'll let you come back in a minute. I think we've got that on mental health and suicide on the work programme to actually discuss. So, Councillor Swift, would you like to come back?
Very, very quickly, and
no problems.
I've been talking to one of the local mental health charities, and the fact that all over the place they're not getting A to Z with money. And I think there was a case up in the Higher Valley where they thought they were going to have to close part of what they did, and then I found in another one they could just get to June. Now both of those have been saved at this point, but it doesn't help with any sort of coordination, does it?
No, true. So it is on the work programme, so we'll come back to that. I think it's something that we need to look at as a scrutiny panel in terms of mental health and suicide and other things such like. So I'll now go on to Councillor Audrey Smith, please.
Thank you. Unfortunately, I've got two things. One was it's just, and you've talked about already, it's just that linking up like the causes of mental health. And I think the pandemic's going to bring up a whole load of additional problems around debt, and debt is known to promote an increase in mental health problems and probably thoughts of suicide as well for many people. But the other thing I wanted to bring up, which is a pet topic of mine, is around active Calderdale and making the roads safe. And I have a real problem that they have taken away our school crossing patrols on roads that are absolutely appalling to cross. And if you've got children, I actually went up Worley Road today at school crossing time, and there's a zebra crossing and a lollipop person, and there was a sea of children going both ways across it. And it was great, but he was there with a queue of cars either side. It looked like quite a dangerous job. But there's other places that, like the top of Gratrix Lane, where it's a wide road with different cars coming in all sorts of ways, and there's no crossing patrol there anymore. And I think it encourages people to walk if they know the children are going to be safe to cross the road. And I do think that losing our crossing patrols is a huge oversight, and I'm sorry, I'm not on this panel usually, but
No, thank you, Audrey. I think it's really useful comment. The only difficulty on that is my understanding is some of the schools fund some of the crossings. Debs, I don't know if you want to clarify that. There's always a balance with the schools that are actually funding the crossing patrols. So it probably...
Yeah, I mean, at the moment, the school crossing patrols that we have are funded. My understanding is they're funded from the council, and we are doing a review of the contribution that school crossing patrols make, if you like, to the sorts of issues that Councillor Smith's mentioning. So safety, feeling safe, and active travel, reduced air quality, improved air quality, etc.
Yeah.
So there is some work underway that's planned to look at that.
Yeah, but it's an important question. It is an important aspect to get people active. Then actually is one of the key aspects. Right. Sorry, I'm just Councillor Holdsworth. I've lost you on the screen. But there you go.
Thank you, Councillor Bagborough. If I might just pick up on that point, I raised the issue of school crossing patrol people being withdrawn about a year ago on place scrutiny, and was told that the academies were paying for their own school crossing patrol people, but the schools maintained by Calderdale were not. So I think there is a difference there.
There is.
My point was about air quality in West Vale. You may or may not know about the Green Action Group. These people are non-political, but they're highly opposed to the whole of the neighbourhood plan developing the land on the left-hand side of the road as you go up towards the Branch Road and Ripponden on Stainland Road. And one of the issues that they are extremely keen on pursuing is air quality. And they're quite annoyed because there's been no air quality assessment carried out in the West Vale and Greetland area. And I wondered if this was something that could actually take place, so we could establish whether or not they have a correct argument, if you like, that the air quality is poor, or that they don't. And I just wonder what we can do about that. Thank you.
Thank you, Councillor Holdsworth. I'm aware that the inspector with the local plan is going to cover air quality as a separate entity, and therefore what I would suggest is actually you submit comments to Minnie Schofield in relation to this particular element. That's what I would suggest as part of the local planning inquiry, if that's okay. Councillor Robinson, welcome to the team.
Oh, thank you, Chair. It's very good to be here, most definitely. And well shared, may I say, as well. Obviously, it's a difficult topic, this, because Debs' team is already stretched. It's maxed out with COVID. It's quite difficult, really, to be discussing the future at the moment. But obviously, we need to do that. What I'd say, first thing about this report, it's almost like we need another column on here. It's one thing saying about delivering it, but then how are we going to measure these outcomes? I think that's a key thing, because then it allows us to then come back and praise how the council have performed. My second comment, if I may, Chair, is in relation to what I believe is one of the biggest killers. It's high blood pressure and it's stress. Now, I'd like in some ways for us to integrate this into the way the council are approaching things. I know when I was on strategy scrutiny board, what we looked at was actually having Active Calderdale giving free memberships, 3-month memberships, trial gym memberships to people who are diagnosed with high blood pressure at their GPs. You might say that's costly, but it's got commercialisation benefits in the long run, because hopefully they're going to get fitter and they're going to keep their memberships. If Debs, if you can put any pressure, I suggested it, nothing happened. If you could help me out with this mission, I would greatly appreciate it. I think it would be a great thing for GPs to offer these services and to promote our memberships.
Thank you, Councillor Robinson, on those parts. I'm sure Debs always takes away useful information from this scrutiny and actions them accordingly. So I have every confidence in that. So I have nobody else indicating on this particular item. So I'd like to now welcome Neil Smurthwaite from the Clinical Commissioning Group. Before I do, I know he would like to promote the walk-in vaccination centre at the Peace Hall. So just to promote it, Neil, and you can do it as well.
Thank you, Chair. So yes, I think we've mentioned it a couple of times, but just to be clear, the pop-up centre at the Peace Hall is for all age groups, so that's now 18 and above. It is for people for first and second doses, so if people want to have their second doses as well, and we're hopefully ensuring that it's the Pfizer vaccine there as well, and not AstraZeneca, which will give us better coverage, particularly in the younger age groups. So thank you for that opportunity.
Superb. Yeah, welcome to the plug. Now, if you'd like to give us a bit of an update, I know we had a meeting, Councillor Barnes and ourselves, because we like to, what we want to throughout the year is communicate with the different organisations so that we're all singing off the same hymn sheet. So you're not surprised when you do come to scrutiny and get a bit of a grilling. So Neil, it's all yours.
Thank you. So there's a number of sort of areas I wanted to ensure that we sort of covered around priorities for the sort of the health sector at the moment. I suppose the big one people may have picked up yesterday is that there is due to be a white paper on the reorganisation of the NHS services and a design framework of, I know Mike will like the acronyms of the integrated partnerships, ICSs, integrated collaborative systems, and integrated collaborative partnerships, which are the place-based. So we're part of the West Yorkshire and Harrogate partnership now, and there is a design framework and a HR framework were issued yesterday. So there's a huge amount of pressure to have new arrangements in place for April 2022, which isn't that far away. People may be aware that Rob Webster, the current chief exec lead for the ICS, is being seconded for 9 months to ensure the setup and we deliver on a West Yorkshire basis. So there's a huge amount going on there, and there's a huge amount about how local place-based arrangements feed into that. The paper describes in quite detail how financial responsibility will be delegated back to place, and our place is Calderdale, so co-terminus with our local authority, and how we can make decisions on the investment and use of that money sort of going forward. So I think we talked about ensuring that the scrutiny were cited on all those sort of proposals and developments as we move along. So there are some timetables that look for shadow things to be in place by sort of October, November. So I think we've got it rightly timetabled to ensure that there is awareness going on. So similar vein to what Deb's talked about around the pandemic, we're very much going into a sort of a reset and prioritisation. We're working closely with partners in the Health and Wellbeing Board to align sort of our priorities for Calderdale and ensure that they're in line with sort of the West Yorkshire and Harrogate priorities as well. So I'll just touch on a few of the main ones there, and apologies, these may sort of trip over into what Ian and Deb says, but it just sort of shows how closely we work together. So inequalities is a key area that we're looking at, and is sort of trying to be embedded into everything we do. And we've done a significant piece of work, particularly on the elective backlog at the hospital, where we are prioritising people with learning disabilities above age and other clinical priorities. And I know learning difficulties has been seen as a priority for Calderdale to look at how we access general practice services and on all other services as well. So inequalities is being ingrained in everything we do. I suppose the three main areas of sort of priority for this next year. One is access to general practice. Clearly a lot of concern about access to face-to-face with GPs, and we're doing a lot of work with our practices to ensure that we have consistent offers, and we have consistent offers in both digital and face-to-face, and recognising the needs of patients. So a lot of work going on there. Some of that trips into the conversations we're having about the urgent care system. So all health and social care systems are currently under huge pressure coming out of the pandemic as as restrictions are removed. So attendances at our A&E and attendances and requests for GP appointments are at an all-time high and exceeding those seen prior to COVID. So it's not just access to GPs, we're seeing access to all urgent services. So that's 999 calls, 111 calls, and out of hour access. So we're doing some work with the hospital around how we can put in different systems and processes to alleviate pressures at A&E, to ensure that there is a smooth transition between those that need urgent emergency care and those that are there are just sort of minor ailments. So there's a lot of work going on of that. Some of that moves into an area we will be looking at, which is our, I suppose, our GP walk-in services that we've had in place over a number of years. People may be aware they've gone virtual over the pandemic, and we need to look at whether they are fit for purposes and whether they need to be repurposed into helping with our urgent care offer across Calderdale going forward. Elective recovery and clearly documented in all newspapers, the level of backlogs in elective care are being worked through in a safe manner through our main trust and our provider. And we are having conversations about West Yorkshire about how they can be accelerated. However, part of the national programme is looking after people and recognising, particularly in the hospital setting, the pressure put on people during the pandemic has been a huge ask, and we're now asking huge asks as we sort of step back up into recovery. So we do have trajectories to sort of exceed the level of demand that's coming through. However, balancing those in the short term is extremely sort of difficult. And I suppose lastly, vaccination, we sort of touched on it. This is still a key priority for us. We're awaiting guidance for the potential third phase, which is likely to be at a similar time to the winter flu. So it coincides with our winter planning and our winter flu program that sort of kicks off from September, October. We're waiting guidance as to how we can sort of mobilise and maximise what we've had with our primary care networks over the last sort of 6 months. So happy to take questions, Chair.
You'll certainly get some, because I think we've certainly been inundated over the last 12 months with the GP surgeries, walk-in surgeries. Certainly my social media one, I think this is a fine example of fire at the GP surgery where we're only doing online appointments. So yeah, it's the type of emails that we're getting on a regular basis as members. So that's probably one of the key aspects, is what timescales are we looking to actually get the GPs up and running in terms of face-to-face appointments, which are a real key. I'm going to bring in Councillor Megan Swift in first of all. I'm sure she echoes that, I'm sure.
Yes, I was going to start exactly as you have, Chair, but I'll miss that bit out now. I don't think there will be a councillor in Calderdale, and probably anywhere else, that isn't getting emails or telephone calls or all sorts, because people aren't getting what they think is the right service and can listen to the doctors. And, you know, we know that they're working very hard, but they're not working hard in a way that they can be seen that they're working hard. You know, you get the thing, it's you're told that, well, nurses are all out, they all see us, why is the doctor having to hide? Now, we know they're not hiding, but that is the perception that they are giving people. And I won't go into personal things, but last week, when somebody couldn't get a 3-year-old into a doctor who was hardly breathing and hadn't in the past, I tried in the afternoon. I tried every number I had got. And if I can't get through to a surgery, I'm not sure that many people can. They went to A&E, you know, bottom line. And I'm sure that everybody's doing the best they can, but it's not working. You know, you go to Siddle and it didn't work before the pandemic, so it's not going to work now. And I don't think people appreciate that normal after it isn't going to be exactly the same. And I have particular worries about some of the smaller practices and whether they won't be used anymore. Sorry, thank you.
No, thank you, Councillors. Perhaps Neil, it might be an opportunity to go away and come back to us with a list of, you know, basically what you're going to do in relation to that specific topic, and equally the timescales involved might be useful for members at this stage. But as I say, equally appreciate the pressures as well. So thank you for that. I'll bring in Councillor Barnes because he might, and then I'll bring you back in, Neil.
I think there's a couple of things. I think you're suggesting there, Howard, what I was going to say. But I think also we need to look at the communication and how each practice has communicated to its patients and dealt with their patients. And I think that is a significant part of the problem, is that people don't know what's going on, haven't been told what's going on, and the first thing they do is when they ring up at 8 o'clock in the morning when the practice opens to find they're 403rd in the queue. And I think that is a big issue. But I think also we need to recognise there is a causal link between why the pressure's on A&E. And the pressure's on A&E because people can't see their doctor. Mm. And they can't see their doctor, and to a certain degree they panic. And the first thing they do when they panic is, I'm afraid, they don't ring 111, they go straight to A&E. And that's just been built into us over the years. And I think those are that's a direct causal link between lack of being able to see a GP or seeing somebody in a GP surgery and going to A&E. But I think Howard summed it up there. I think we need to look at that, and we also need to look at why the communication has been poor, and also whether or not individual GP practices have actually followed the guidelines. Because I think that's the other point, going back to what Councillor Swift said, is I've had emails from people at different practices saying saying their practices have told them different things.
Yeah, thank you, Councillor Barnes. Neil, do you want to come in at this stage?
Yeah, thank you, Chair. Access and consistent access in Calderdale is a top priority for us. I'm not going to comment or speculate on individual cases, because I think part of the communication, we actually need help from councillors to be consistent and to help us with some of those. And we have engaged with our GPs, and we're using the voluntary sector to help with that communication, to help improve it. And I think they're starting currently at the moment to sort of help with some of the vaccination stuff. So I'm happy to sort of take that away, but I don't think this is the appropriate place to speculate on people's individual things.
No, totally agree on that. I think
we have done a lot of work, Mike, around trying to correlate GPs, and as you're right, there is a bit of an anecdote that this is years. This isn't just post-pandemic. This is years of not being able to access and people going to sort of A&E. But when we do audit that and we substantiate it, and this is where we get into difficulties, because we've done a bit of it lately, where people say they can't get into see their GP. We actually find a lot of people have been in their GP. They don't like necessarily how their appointment is phased or what the answer is, and they go somewhere else. So we get that a lot with low-level things, particularly around antibiotics and things like that. So it's not that one is always shut. That there are loads of things to go at here, but there is, and we recognise communication, particularly to patients, around how to access, how busy things are, is vital up there. We get at the moment is an 8 o'clock rush to get an appointment, but we have lots of virtual access, and the level of appointments, even face to face, are now higher than pre-COVID. So it's not that GPs are hiding at all, but we've clearly got to do something on comms.
No, fully appreciate your comments, Neil. I think Councillor Hutchinson in the past has raised the issue that actually the face-to-face contact, actually you pick up other symptoms. So you actually look at somebody, you can say, well, actually, what's the cause? What's the underlying cause of this? So that's the key. So we acknowledge that. We want to work with you. We are your critical friend. So actually, we do want to work as a group to actually ensure that the communication is effective, is clear and concise, and people know exactly what they need to do. Clearly, we're not talking specific examples, but we're looking at the overall service and looking towards improving that and helping you to improve that as well. So I'm sure you'll be aware of that. Anybody indicating else to speak? I know we're going to on the work programme. We have indicated that we may do a white paper like a COVID report in a day. So scrutiny in a day for the white paper as we go along the process to ensure that members have the opportunity to feedback on that. So that's something that we'll pick up on, Neil, if that's okay. So I'm now going to move on to Ian Baines, and he has a presentation which I'm sure most people have seen the presentation, and I'm sure Ian will talk us through some of the main points.
Thank you, Chair. One of the things going last in the order of 3 is that some of the things I'm going to talk about have already been mentioned both by Debs and Neil, so I'll try and skip over those. But if anybody's got any questions, and again, apologies to Councillor Barnes, I think I failed on slide 2 because I did use an acronym, but I will explain what it is shortly. So I thought it'd be useful just to kind of set the priorities in a bit of context, and clearly the whole health and social care system is starting to think through how it plans for its post-COVID period, and adult social care is no different. I think some of the things that we need to be aware of, and I think Scrutiny might want to look at during the year, is that we do know that in terms of biggest impact, the residential and nursing home sector was at the forefront of the pandemic. So one of the things we need to kind of understand is how quickly will those settings be able to bounce back from the kind of 15, 16 months of fairly static occupancy and in some cases decreased occupancy. The positive note for Calderdale is that pre the pandemic, occupation levels in residential and nursing homes were around 84%. And when I looked at them this week, they are around the 80%. So there has been a shift, but most care homes do operate on an assumption that if they're 80% occupancy, they're that whilst it's still tight for them financially, often it's when it drops below 80% is where you start to worry. So we do need to think about how long might it take for people to have confidence back in that setting for people who need residential and nursing care to come forward. What we also know is that the workforce has gone through, like many sectors, gone through quite a long, emotional, difficult time. And what we want to try to do is work with the sector to make sure that we can retain those really skilled, experienced staff. But we are starting to see, for example, in some of our registered managers who work across our provider market, starting to think about, actually, I've gone through 18 months, I think I need a rest. And what we need to do is support them to make the right decision. But if there are gaps in registered managers, we need to find a way of supporting potentially new registered managers coming forward. We've talked a lot about the inequalities that that COVID has managed to expose. Some of those inequalities were there before COVID. It simply amplified it. And we often talk about wanting to build back better. And I certainly want to build back better. But if we build back better and don't address some of those structural inequalities, we won't have a fairer health and social care system. So for me, there is something about recognising that we need to build back fairer as well as better. For members of the board that have been part of Scrutiny for some time, and apologies to new members, you will get used to me talking about the importance of adult social care reform and the importance of a financial settlement in terms of the future of social care. Consecutive governments have failed to deliver on a solution to long-term plan. I'm optimistic that in the Queen's speech, government said they would bring forward a plan, but I think the importance of bringing that plan in a timely way is quite critical when we link that back to the issue of that post-COVID recovery. The social care market is has been on its knees, and we need to make sure that we can have a long-term sustainable funding to make sure that that's possible. Department of Health and Social Care, which is my one acronym for today. Neil's talked about the white paper that's around the integration and innovation white paper. It does impact on the NHS. It creates a statutory footing for the integrated care system. But also what it will do is it will create something called an integrated care partnership, which will be about actually how at Calderdale do we come together to deliver place-based solutions that are right for our populations. And clearly social care will play its part in that. One of the other things the white paper does, which again Scrutiny might be interested in just keeping an eye on, is it brings back the potential for a formal inspection regime for adult social care. There hasn't been one since 2009, so it will bring forward plans for what that will look like. It's more likely to also include how we work in partnership and collaboration with our partners, but that might be something that would be really helpful. And I suppose the other context of this is, and people will, if people think back to 2019, for those of you that were on Scrutiny then, I came in late 2019 and set out what I wanted to achieve with the directorate, and we started a restructure. We did the first phase of that. Then we had the pandemic, so there is still some work to do on really going through to the next phase of the restructure. So we've had to pause some of the activity on transformation, but actually it's not going away. We will come back to that now that we're starting to be able to look above the parapet and start to think about other things. I'm not going to try and dwell too much. Do you want me to stop and take some questions as they're coming?
No, if you just continue. We've only got one person indicating in the moment, so if you want to continue, and then we'll take the questions at the end, if that's okay.
So what I thought I'd try to talk you through is 4 broad areas that we're saying are our big priorities. What we've tried to do is say what our ambition is, the priority inside that, and then some things we intend to deliver. So it's always a little bit dangerous saying to Scrutiny, these are the things we're going to deliver. And I know you want to hold us to account, you want to be our critical friend, but these are the things I'm saying that within a year, we will have made big progress on these things, and you'll be able to tangibly see some of these things happening. So we have an ambition, and this is shared with Cabinet as well as officers, that we do want to improve the quality of life for people who are in need of adult social care. And we don't want to simply just deliver a service. We want to make sure that they feel connected to their communities, that they have rich and fulfilling lives. So one of the things that we're committing to do, and Cabinet are really clear that they want to do, is to sign up to become an age-friendly community. We hear a lot about being inclusive, but actually some of the development work that we're thinking about in terms of how we think about our town centres, it can so easily forget, we can so easily forget that older people want to be part of town centres, they want to be available, but actually if we don't build in things that will attract older people, they can feel quite excluded. So we want to sign up to be an age-friendly community, and we don't want to simply sign up, we want to create an age-friendly partnership that will have older people at the heart of that and be our critical friends on making sure we do the right thing. We do want to make sure that we invest in the voluntary sector, and I know that Scrutiny members have already tonight talked about the importance of the voluntary sector and the insecure funding, and we're keen that we want to invest in the voluntary sector to help us connect people to their communities. We have and we will continue to engage with Active Calderdale. You'll have heard me previously talk about adult social care's involvement in Active Calderdale, but we believe that if we can get people engaged in physical activity and motivated and moving, then they will be able to maintain their independence for much longer. And I think because we know that dementia is a growing concern, not just in Calderdale, but across the country, we want to develop a model that I've described as a centre of excellence for dementia. And what that will do is create a one-stop shop for people experiencing dementia, whether that be the person themselves or the families, the carers, so that they're not having to go to 3 or 4 different places in order to get all the information and support that they need. It will most likely be in one central point, but we're also clear that this is not just if, for example, it happens to be sited either in Brighouse or Halifax. It's important this is a borough-wide facility. So we'll be looking at how we can create a hub model so that we can actually reach more isolated towns and communities, because we recognise that for people with dementia, that travelling great distances, whilst it might be getting everything in one place, it might be really helpful that they can actually get some of that locally as well. The kind of next big area of activity that we want to engage in is that we want to have alternative provision in terms of accommodation, so becoming less reliant on residential and nursing care, but build something called extra care. So we already have a number of extra care facilities. We also know that people with learning disabilities want to live in supported living and have independent tenancies. So we're committed to refresh our investment in some older facilities that are probably need updating and could be better quality. So the things that we're keen to do are, we will Scrutiny will know that we did have a care home in Todmorden called Fernie Lee. What Cabinet are committing to is to use that site for an extra care facility. There isn't an extra care facility in that Upper Valley area. And when we talked with the local community, who were really concerned about Fernie Lee closing, we said we would involve them in shaping the design of what that would look like. So we will be bringing forward plans for how we'll develop that site going forward. In Brighouse, we've already commenced work, and building work will continue through 2021 on some on Railway Bridge View, which is extra care specifically for people with dementia. And we're hoping that that work will be completed this year. We were hoping we'd open it this year, but with COVID and some of the challenges with construction, it's likely that it will complete at the end of this year with an opening in early 2022. We want to we think we could do with an extra care facility in North Halifax, and we're currently working with colleagues in planning and regeneration to kind of think through where there might be good sites in North Halifax. And we are about to formally open a 14-bedded supported living unit for people with learning disabilities in what was the old courthouse building in central Halifax. So hopefully that gives you a flavour of some of the ambition and some things that we will deliver.
Fantastic, thank you, Ian. Certainly at this stage, I'd like to say that actually the Mayor's charity this year is going to be the Alzheimer's, but a focus on younger adults that have got Alzheimer's, which I think is really useful to go inside. Right, I have Councillor Hutchinson, who's indicated that he would like to speak. So Councillor Hutchinson, please.
Thank you, Chair. Ian, I noticed in your report that the rather sort of Delphic statement that we would be committing and working towards the ethical care charter. I mean, you're well aware, as you've alluded to, social care is nothing if it isn't the workforce and the people delivering the care, and having motivated staff who have the time to do that aren't rushing from one client to the other and shortchanging them is so important. I was wondering, you know, Leeds, Bradford, York, Sheffield have all committed to the Ethical Care Charter, which was produced in 2012. Where are we in terms of adopting it here, in terms of committing and working towards it? Because my understanding is that there are 3 stages outlined in the Care Charter. I was just wondering, what were the sticking points in Calderdale not adopting it?
Yeah. Really helpful question, and I'll try and give it a fullest answer as possible. But if you feel that I've missed anything in particular, I'm more than happy to have a conversation outside of the meeting. So for people not as close to this, the Ethical Care Charter is about signing up to a set of principles that are about investing in the working conditions and support to care workers directly. And there are 2 ethical care charters, one for people who work in residential and nursing, and one for people who work in home care. So we've adopted some of the principles, certainly within our commissioning intentions, that sit within inside the the Ethical Care Charter. One of the things that we've not quite formally signed up to is the commitment within a 3-year period to meet the real living wage. You will know, Councillor Hutchinson, that this year Cabinet made a decision to invest above the national minimum wage to start to make inroads into the real living wage, and went with a higher rate of fee to include reaching what is now the low pay commission rate of £9.21. And what we did with all our providers is talk to them through a variation of contract to make it a contractual obligation that if they accepted the additional payments, that they would passport that increased fee directly to their employees. As an officer, I'm really clear that I want to bring forward plans that how we'll move towards the real living wage in a 3-year period. I know Cabinet are really keen to explore that, but there is a big bill at the end of that. We estimate that if I was trying to achieve the real living wage today, I would probably need somewhere between an extra £4 to £5 million in the budget. So when I talk about the importance of a long-term financial settlement for social care that recognises the value of social care workers, that's where I think we have to apply some pressure nationally. But we are committed to work towards it. Interestingly, and I think this is probably where it's helpful just to understand that some authorities and some of those that you've named have signed up to it, but what they've done is they've committed to a different rate of pay that's different to the real living wage. So they've done everything but the final bit. I'm hoping through the process of the next year or so, we'll formally commit to the full Ethical Care Charter.
Thank you. And before I bring you in, Councillor Fenton-Glynn, I was going to bring you in because it was I wanted to give you a bit of a limelight as it's your first meeting. But before I actually do, I think we should put it on record as Adults Health and Social Care Board. Our great thanks to Councillor Metcalfe for all his long-term service, for all the work he's done. He's been extremely dedicated to the adults. He's got an absolute wealth of knowledge. I did speak to him over the last few weeks and acknowledge my personal thanks to him for actually being very passionate about this area. I'm sure most members will agree who's been in contact with Councillor Metcalfe that is extremely passionate. One thing, and I'm sure Councillor Fenton-Glynn is equally going to go on about, is actually, yes, we do need long-term settlements. Yes, we do need a long-term better financial package in terms of where we're going from, and I think that is acknowledged. So Councillor Fenton-Glynn, welcome to your new role. I'd like to give you the opportunity for a few moments, just so we can move the agenda along as well, but clear some of your thoughts for the year ahead, because I'm sure we'll be working with you, scrutinising you, giving you some tough questions, perhaps this year. I'm sure it'll be equally the same. So the floor's yours for a few moments, please.
Yeah, I mean, I'll start with the Ethical Care Charter because I think that's probably quite a good place to start. Going back to what you said about Councillor Metcalfe, it's kind of a lot of what I'm doing is just building on just a fantastic department that's been left to me by Councillor Metcalfe, and our adult health and social care is a lot stronger because of Bob's work, and it's really important to put that on record that actually, as an authority, kind of over 11 years, and that level of expertise is just hard to beat. So yeah, I've got something to live up to. Please excuse the sound of gospel singing behind me. There's something going on the street because I live in Hebden Bridge, and I don't really know what it is, but it's if you do hear the gospel singing, that's why. In terms of the Ethical Care Charter, I think it is something that me and Ian have been looking at kind of around the finances. It's a big chunk of change that it costs. And particularly you look at that in the context, it's got £102 million budget. So that's kind of we're talking almost 5% of the budget, which for anything is quite a lot. But what we need to look at, staffing is about 2/3 of our budget anyway. So what we need to look at is how we can go from one point to the next point, and in a way that keeps Nigel, our head of finance, happy. And so that's the challenge for us. But actually, I think we've shown real intent with the above inflationary and above recommended pay rise, and it was absolutely the right thing to do, because there's only so much kind of that a clap will buy people, and actually more than just clapping on our doorsteps, which everyone did and everyone felt, we have to recognise that the people that got us through this crisis were those frontline care workers, and it was really important to all of us, I think. And that's kind of on a cross-party basis. I think we're all quite proud to be from an authority that have recognised that and done something on that. But moving on in terms of my priorities, I was given some really good advice from a friend of mine who's been head of adult health and social care in another authority. She said that don't try to do everything all at once, because you're going to spend your entire time kind of running to catch up, and you'll probably not be the most effective officer. So kind of look at a couple of areas where you can make a difference and focus on them. So that's kind of what I'm going to try to do at the start, and hopefully I'll learn what I'm doing on the way. So in terms of my priorities, I think one of my main priorities is looking at some of the dementia work that we're doing. One of the reasons I've chosen that to prioritise is actually it's one of the most complex areas. And actually, if you get the complex stuff right, then the kind of not the more simple, but the kind of the more straightforward stuff will follow. So it's can we get these complex things right? And actually, when I've dealt with casework to do with adult health and social care, it is often that people trying to advocate for others and having to hit several different points. Everything I say sounds slightly more inspirational because I've got this rising gospel choir, but so it's so you're kind of giving a bit more. You're getting kind of the more straightforward things are a bit easier to get right. So that's, I think, going to be one of the priorities. Another priority that I'm going to look at is the kind of that first interface and that first conversation. I'm sure at some point you'll be having a look at the Burnt Bridges report, which looked at the individuals with multiple complex needs in Calderdale who died in 2019. And actually, one of the things that was clear there is that sometimes that first point of contact didn't go as well as it could, which is a similar kind of, it goes back to the dementia stuff, but it's not quite the same thing. But it's making sure that when people go and ask for help, they actually receive that help. And part of that also, and I think this is my final thing is how we work with our partners, because we don't do direct provision in adult health and social care, we do less of it. So the key thing is making sure that when people talk to our providers, they get what they need as well, and they're working in a way that reflects the values of Calderdale, and making sure that when we look at how we procure our providers, how we work with partner organisations, that everyone's doing what they what we would hope represents a Calderdale care service that we can all be proud of. So those are kind of my priorities.
Yeah,
super. First point of contact and working with partners well.
Thank you, Councillor Fenton-Glynn. I'm sure we'll be able to work with you on those ones. Equally, I mean, we've had Councillor Barnes and myself have had a meeting with the Adults Safeguarding Board, and we're having regular meetings over the course of the year. So actually, issues like burn bridges, we're aware of issues before they come to the forefront. I think it's a real key. Equally, we've given him the opportunity to settle in a few weeks, but equally, Councillor Barnes and myself will be setting up some regular meetings with yourself to see how we can work on some of your priorities as a scrutiny panel as well. So thank you very much for your thoughts and your aspirations for the year. We'll look forward to working with you on those. So I think Superb. So thank you, Debs, Neil, Ian, for contributing and give us an overall picture. It's always useful to know where we're going from the start. It doesn't always end up at the end because of different things that come along, but I'm sure we're all ready for a new challenge, and the new challenge is working post-COVID, and let's get on with not some form of normality, I guess. So after that, we're going to go on to item number 7. So I'm going to let Councillor Mike Barnes take the lead on this, because he's been taking the lead on the dentistry a project, a very close to heart subject for a councillor who was a former councillor, Marilyn Greenwood. So Councillor Barnes.
Thank you, Chair. I'd also like to say it was good to spend some time with Councillor Benton early on this week to bring her up to speed as she is joining us on this work. I think in summation, work is progressing, but I think we have to acknowledge it's slower than we would probably like, and there's a bit of frustration there. I think the subject matter is very significant and growing moment. We are looking to address this in bite-sized chunks. So I think that's a pun that's been going around this subcommittee since this subcommittee formed, and beholden on me to maintain that pun throughout the whole of this exercise. I think our initial assessment is that the system is cumbersome, overly complicated, bulging at the seams, and that there is a bit of a silo mentality within oral and dental health. I think we recently met with Sharon Pearson, who NHS England and NHS Improvement, who are responsible for this. This is and they do the commission on this, and we looked at commissioning and prevention. And I think it's reasonable to say that the meeting didn't provide us with all the answers. I think actually it left us with more questions than answers. And I think we did ask for various bits of information, which, unless I'm mistaken, we still haven't. Well, we hadn't received it earlier this week, unless Mike knows differently. So, and that information is key. That information is key in a number of ways. It's key because it explains a little bit where the sort of start process in regard to dental treatment is commissioned, and also the amount of NHS dental treatment that is commissioned in an area. But also within the system, as I said, is very complicated and inflexible, with a thing called UDAs, which are units of dental activity. There we go, Ian. I got my own triple letter acronym in there. And the essential purpose of the UDA is to measure the practice's activity and to ensure that the correct amount of patients' charges is collected. What it means is that everything's fixed and it's fixated upon that, and it isn't looking outside that. It isn't looking at flexible. It isn't flexible. It isn't looking at anything other than a prescriptive and an inflexible commissioning structure. So one of the things that we were talking about was flexible commissioning, and how part of those UDAs could be used by dental practices to do something different, to not just to look at somebody's teeth, but how to go out into the community, how to look at hygiene, rather than just a 6-month checkup, bang on to the next one, bang on the next one. So that's stage one, and we're waiting for that information to be able to give us some ideas on that one. And the idea is how we can then bring some flexible commissioning within Calderdale to improve. And we have to remember the whole purpose of this is to improve the outcomes. I remember when I first sat on this committee, I hated that word outcome, but I think it is a word that unfortunately is very much in the vocabulary of this. So that's sort of stage one. So what we're looking at there is how we can bring that in, and there are some case studies as well, which will allow us to speak to those dental practices and look at that. So the next stage then would be to involve local dental practices, but also look at communication. And I think it's a theme actually that we've seen tonight is communication, and how communication is very effective, and when it doesn't work, the problems that it has. One of the original committee members was talking about the number of children that are not receiving the dental treatment, and is that down to lack of communication? For example, when a parent rings up a dental practice, and the dental practice says, "We're not taking NHS patients," well, that's actually not valid for children, because children receive free dental treatment. So is that parent actually getting the right communication messages to say, well, actually, I'm ringing on behalf of a 6-year-old, and actually that's free treatment? I'm not asking for me. So there's all these sort of things. So we need to look at that one. And then I think the third final chunk is to look at the overall health strategies involving Public Health England, tie all the strands back together into the joint Calderdale Kirklees Oral Health Advisory Group and the Health and Wellbeing Board. So those are the three areas that we're going to do within that. So that's basically a brief report. And any questions?
Thank you. It sounds like you've got your teeth into it. Oh, bum, bum. Sorry about that. Councillor Megan Swift.
Right, thank you for that, Mark. You've a lot more knowledge there on dentists than I am. But I don't like dentists, I'm terrified of them. So for the last few months, I have been trying to find a dentist. And a little bit of it was my fault, because when they said, you know, but we can't really see you till the end of June or July, and we were back in March, I'd say, well, never mind, I'll look somewhere else. I finally got somewhere, not on the NHS. One dentist told me, as far as NHS was concerned, it would be 5 years before they were taking any. And, you know, I may not like them, but my teeth needed to be done before 5 years was up. But it cost me nearly £100 to go for an assessment. And it will cost a lot more money. And I'm not criticising the dentist I went to or even naming them, because, you know, they saw me, others didn't. But I don't know what an adult who can't afford that £100 and then whatever it is afterwards is supposed to do. And, you know, yeah, I remember Helen Riveron, going back a little bit, ringing up and saying something along the lines of, I can't get a dentist, Megan, I've been everywhere. You know, and if I can't find a dentist, go, you know, with the knowledge that she had,
yeah.
She found one, but it wasn't National Health. So I just wanted, as an individual, to add on to Mike's comments that, you know, fit the whole thing really.
Yeah, thank you, Councillor Swift. I actually had a meeting with the Buchanan Town Hall dental practice, and they do an awful lot of charity work and a lot of work.
Yeah.
And I know that the committee will take some of and have them hopefully interview them and get to know what they're actually doing as other work and free work that they're actually doing as well. So I think it's really important to.
Councillor Benton raised that on Monday, and I think that's a very, very, very valid point. I think that's one of the points that we need to address is who, you know, this determination of need within Calderdale, but not just the determination of need within Calderdale, which apparently is a document which I don't think many of us are aware of, but also who determines who gets NHS treatment. You know, it is a situation. We have to remember that the dental system is private. The dental system in the UK is private, and the NHS buy parts of that system for those. But it's who determines who is subject. Is it based upon the need of the individual or the circumstance of the individual? I think neither, really. I think it's just based on a first come, first served basis.
Yeah. Well, certainly look forward to supplementary reports on that. I'm going to bring in Councillor Hutchinson, and then I'll bring in Mike Lodge on this matter and bring it to a conclusion on this one.
Thank you, Chair. I mean, Councillor Barnes has alluded to this. I was going to ask whether there was any actual assessment of need for the population of Calderdale. To the best of my knowledge, there is the NHS budget that's allocated to dentistry is only just over 50% of the estimated need for that care. So it's not surprising that people are running into access problems. But I just wondered whether we had an accurate idea of what the gap is between need and what is available in the area that we're concerned about.
Simple answer, no. That's actually a question we have asked. So we have asked to see that document which drives this process, Colin. So when we get that, we'll be able to report back on that.
Superb. Thank you, Mike, for that. And Mike Lodge,
who's on mute?
He's on mute.
Schoolboy error.
I thought I'd taken myself off mute. Sorry. Just to add on the business of the working group, I had a very useful meeting with Ben Lehman and Rachel Smith from Public Health Department this morning as a preparatory work for the members meeting them. They are both much more expert than me, and they, although there is information, I'm going to come in with a 4-letter acronym, JSNA, the Joint Strategic Needs Assessment. There is some information in the Joint Strategic Needs Assessment, but the links between that and commissioning decisions by NHS England are vague, probably to say the least, in their view. They talked to me about some of the really important initiatives that are done at a local level in Calderdale, and that'll be the third part of the work that Councillor Barnes was relating to. And just to say, we have put an item on the draft work programme, you decide your own work programme, but on the draft work programme for next month to report back on commissioning, the commissioning discussions we've had, but that will be dependent on getting some more information from NHS England. We won't be able to bring that report if we haven't got that information.
Excellent, thank you, Mike. So continuing, we'll receive further reports on that, Councillor Barnes, if that's okay. So we move on to item number 8, which is the appointment of members to the Calderdale and Kirklees Joint Health Scrutiny Committee and the West Yorkshire Joint Health Scrutiny Committee. Right, Mike, do you want to lead on this one?
Thank you, Chair. This is something that we ask you to do every year. We have currently 2 joint health scrutiny committees, the West Yorkshire Joint Health Scrutiny Committee. That is not a statutory joint scrutiny committee, but it does have a very important role and an increasingly important role in scrutinising the work of the West Yorkshire Harrogate Health and Care Partnership, which is Neil and Ian and Debs have talked about, becomes a statutory body in April, so that's an important body. We have each of the 5 councils in West Yorkshire has 2 places on that, and those places are currently held by Councillor Hutchinson and Councillor Baines. So there is a need to reappoint to that. As it happens, there are 2 North Yorkshire councils also co-opted onto that body. So that's the first. That's one thing we're asking you to do, is to appoint 2 members to that joint scrutiny committee. We have the Joint Health Scrutiny Committee with Kirklees. That has existed since 2014, I believe, and has been focused solely on the hospital reconfiguration plans, now focusing on ensuring that the implementation of those plans is consistent with what members of both councils would like to see, and what the Secretary of State, the former Secretary of State, Jeremy Hunt, said when the issue was referred to the Secretary of State. We have 4 members on that scrutiny board who are currently Councillor Swift, Councillor Blackburn, Councillor Hutchinson, and there's a vacancy because Anne Collins, former Councillor Collins, was the 4th member on that. And the third thing we ask you to do is to nominate a lead councillor from those 4 to work with the lead councillor from Kirklees, whoever that is, currently Councillor Sage, but will be reappointed. So three nominations, sets of nominations.
Right, fabulous. Thank you, Mike. Let's take the Joint Health Scrutiny Committee. Hopefully, Councillor Hutchinson would like to continue to be on the committee. Hopefully, fingers up for that. Secondly, actually, with your knowledge and expertise in that field, I propose that you still did the lead on that because of your expertise, knowledge on that, if that's okay. So equally, I would like to continue to serve on that joint scrutiny committee. So it's a case of Councillor Megan Swift, are you happy to continue to serve on that as well? So we're looking for a 4th member to serve on that. Councillor Hutchinson.
I'd like to nominate Councillor Barnes.
And and I will second that. I was going to propose him anyway, but yeah, absolutely spot on. So we've got a full team of people there, so I think that's fine. So if you're okay, Councillor Hutchinson, to lead on that, I think it's useful for somebody else to lead as part of, and we all work together anyway. So that's perfect on that. Right. So the West Yorkshire Joint Health Scrutiny Committee, the 2 members, or the member from our side is Councillor Stephen Baines wishes to continue on that. So with members' approval, I can put him forward. And the second person, just remind me, who was the second person? Oh, Councillor Hutchinson, you're still on that. Yeah, you still.
I would love to continue on that.
Then we wouldn't want to take it away from you.
Thank you very much.
Absolutely. So I think that's the official business that we've got to do on item number 8. So we'll move on to item number 9, which is the work programme. Now I'm just going to bring Councillor Swift in because I cut off Swift at the beginning. So Councillor Megan Swift.
Sorry,
Yes.
Chair, can I just stop you there? Are the rest of the board happy with those nominations?
Oh, sorry.
We've put them forward. Just wonder if everybody else is.
Is that it? Thank you, Kirsty, for putting me right once again.
It was a deliberate ploy, Kirsty, to make sure you were still there.
Yeah, it was. I was just to make sure you're not falling asleep. So members, all in favour of those nominations on both those scrutinies. Yeah, perfect. Yeah. Excellent. Okay, thank you very much. That's now official. So we can now move on to item number 9. But before I do so, I'll bring in Councillor Megan Swift in relation to items on the minutes, I think.
Yes, please. It's not necessarily the item of the minutes.
Yeah.
It was the report that we looked at on the homeless people who were
the burn bridges. Yeah.
And I know it's coming back in another month. The only thing I would say about the minutes that I found a little concerning, they were a lot more optimistic than I felt in the meeting, and we didn't seem to. They didn't. I mean, I'm not asking for them to be changed, Chair, but they didn't seem to just the importance of. But that's my opinion.
No, it is really valid, Councillor Swift. I think when we had a meeting with them, they fully recognise actually how serious the committee took it. Actually really welcomed our meeting with them, because I think actually following that meeting they went away a little bit well, in some ways rightly actually going away with a slightly not upset but actually slightly challenged to say the least. So they weren't, moving forwards, this is the communication moving forwards. Actually, we want to ensure that when people come to our scrutiny, that they're not shocked in relation to some of the issues that are going to be raised, and they're prepared as well to give a full answer as well. So it's a really valid point on that. So is that everything you needed to add on that? I didn't want to.
Can I just add one other thing?
Of course you can, yeah.
I mean, they're coming back, aren't they? Is it the July meeting?
They are indeed, yes, yeah.
And I haven't seen who's coming from other organisations. But some of the local ones have quite a lot to do with people on the street, and it would be really good to have a few people there. And I'm not criticising council officers at all, but just for a different input sometime. Yeah,
we'll certainly take that on board, and we'll liaise with Mike, the two Mikes. So we'll certainly do that. I was going to make a joke there, but I won't. So the work programme itself has been circulated. I always say to this to members, my door is always open. Actually, if you think there's things that we need to include in the work programme, then I'm always happy to listen, take on board. We're having regular meetings with Councillor Barnes, officials, Mike Lodge, and the likes, working with Fazana equally to ensure that she's on board and helping us with our scrutiny, detailed scrutiny, and scrutiny in a day in terms of things like the white paper. So unless anyone has anything to add in relation to the work programme, can we take that as it is at the moment, members? Yeah, perfect. Yeah, all in agreement? Can I just show of hands? Yeah. Perfect. Better say, if there's something you want to add to the agenda, my door is always open, and I'm always there to listen and take those things on board. So it's been a fairly lengthy meeting, but actually it's been an extremely useful meeting, I think, members, and some extremely useful points moving forward. I think we're singing on the same hymn sheet in terms of our focus. I look forward to working with every one of you and organisations, as outside organisations as well. So it beats me to close the meeting, and thank you for your